All right, the record button is going. I think we're ready.
Excellent. We will go ahead and call to order at 12:01. Thank you, Shelley. Just a couple Google Meet housekeeping reminders. These meetings are recorded and publicly posted, so anything that's on the video or in the chat box is recorded as part of the meeting minutes. Please keep your microphone on mute when you're not speaking. If you're on the telephone and you need to unmute yourself, it's *6 to unmute yourself on the phone. Shelley and Julia will be monitoring the chat box for any comments in that section. And because we are a virtual meeting, once again, please identify your name so that we know who is speaking first. And we will go ahead and do roll call. Thank you, Shelley.
Sorry. Got 10 things going on here. Let's see. Dan Spate.
I'm here.
All right. Franco Castro Marin. Frank Walter.
Here.
Gail Bradley.
Present.
Jason Johnson.
Here.
Josh Gaither.
Here.
Julie Augenstein.
Here.
Kevin Foster. Kevin, we might need to do a mic check with you. I see you listed. And Michelle Preston.
Here.
And Ryan Page. She indicated she would not be able to make this meeting today. 2, 3. I count 8. We do have quorum. Thank you, everybody.
Excellent. Thank you very much, Shelley.
Hey, this is Foster. I'm here. I couldn't get my mic turned on.
Oh, not a problem. Thank you. We captured you.
Thank you.
Thank you. All right. Attendance report. Please see attached that Shelley has. We have had 2 very recent resignations. Once those are finalized, we will publicize that. It's like Dr. Casperman joining as well. But we do currently have a vacancy for physicians specializing in cardiac care. We will also have a vacancy for a physician from Northern Region, as well as Dr. Zeiman has also resigned her role due to meeting conflicts as well. So we will make sure that those get publicized as vacancies. We would like to welcome Dr. Castor-Marin as a new member to MDC. So welcome Franco to the group. And next up, I will hand over to Julia for just a brief report on naloxone. Thank you.
Good morning, everybody. I just want to remind everybody that we do have free naloxone available to first responder agencies through the FR Care grant. The link to request naloxone is on the agenda, as well as a link to information for our most recent training, which is the roadmap for first response encounters of patients with potential substance use disorders. If you have any questions, you can reach out to Joyce Hospodar or myself. That's all.
All right, thank you so much, Julia. Next up for Bureau Report, Chief Garcia.
Good morning, Dr. Gale and all. Can you hear me?
Yes, thank you.
All right, well, good morning. The Bureau of EMS and Trauma System continues with normal business operations. I'll give an update on rules, emergency orders, and waivers. The department continues to seek stakeholder feedback on the rulemaking process for EMS Air Ambulance, Articles 7 through 8, and Ground Ambulance, Articles 9 through 11. Articles 7 through 8 are being reviewed for final comments before a formal notice of proposed rulemaking is filed with the Secretary of State, and there will be an additional 30-day review period for public comment before going to the Governor's Regulatory Review Council for approval. The remaining process before adoption will likely take until summer 2021. The Article 9 work group will continue to meet on a monthly basis to provide feedback on the ground ambulance draft, and the department will seek additional stakeholder input on Articles 10 through 11. ADHS continues to support the COVID-19 response, and the Bureau of EMS and Trauma System has compiled some updated information on resources to support providers during the pandemic. Some of the most recent information was sent out via our Gov Delivery Bulletin. including Executive Order 2020-63, which extends the Good Samaritan order to provide healthcare workers and EMS providers acting in good faith with immunity protections. That is expected to remain in place until March 31st. There is also Administrative Order 2020-15, which provides limited EMS rule waivers, including flexibility on CON boundaries through March 31st. Most recently, ADHS issued Emergency Measure 2020-05, authorizing all levels of EMCTs to administer COVID-19 and influenza vaccinations, as well as perform viral testing with prior written approval from an administrative medical director. There is no specific expiration date on this emergency measure. We expect that it will remain in play for 18 months. ADHS has also updated EMS patient screening and training resources on our website, in addition to treat and refer protocols that are all available on both the EMS website as well as our azhealth.gov COVID website. During this current surge, we continue to encourage EMS providers to transport patients to the closest, most appropriate hospital, and we'll be sure to provide additional updates and guidance through GovDelivery and our website as more information becomes available. Of note, we've most recently published an updated vaccine website, so folks can find vaccination sites and resources in their community. Please visit azhealth.gov/findvaccine for some more recent information. I'd also like to share with the group that we are in several staffing transitions right now. Our team continues to be tasked with supporting the COVID-19 response, and as you know, I'm currently wearing several hats for the department as I transition into the bureau chief role. We're also in the process of filling several vacancies, including the compliance and enforcement manager and a health program manager position, which we hope to be able to announce soon. We have a services section chief position formerly held by Ben Fisher, which will be posted soon for active recruitment if it's not already live on our jobs website. The last update I'll share is regarding scope of practice. Based on feedback from the statutory committees on updating scope of practice in rule, the department is reviewing options for exempt rulemaking that will likely include filing a notice with the Secretary of State and providing an additional 30-day review period for public comment. If there is a need for additional emergent updates to scope of practice that must be implemented sooner, in some cases, the department has the ability to implement an emergency measure to be able to amend scope based on current needs. An example of this would be the mechanism that we've utilized with the current emergency measure to allow EMTs to administer viral tests and immunizations. We'll continue to keep you all updated, and that's all I have for now, pending any questions.
All right. Thank you very much. I appreciate the updates. All right. Next up, we're going to do Vatsal for opioid and out-of-hospital cardiac arrest. This data was requested by some of the stakeholders, and so we wanted to make sure that we brought this forward. So thank you for Vatsal preparing this data with her team.
Sure. Thanks, Dr. Bradley. I'm going to share my screen. We'll talk about cardiac arrest first. What you see on the screen is there are two graphs. One is a cardiac arrest incidence total volume, and another side is showing the patient disposition with the cardiac arrest. So with the cardiac arrest incident, it's divided into basically three rows. So cardiac arrest incidence, then the cardiac arrest percent, and then what you see over here is the rate of cardiac arrest per 100,000, which takes into consideration the population increase over the 3 years. And so we have 2018, 2019, and 2020. These are the 3 years over each month comparison. And what we see is that there is steady increase over the years. Every month we see that. But then what we saw is kind of like April, May, June, July, the difference is quite a bit, and that we are still observing it. It's in December, that's the latest data we have, and we still observe, we see that the number of incidents is quite high compared to the last 2 years. And when we take into account the population, for all 3 years, the rate also seems to be on the increasing side for the 2020 year compared to the last 2 years for each of the months. And on this side, the graph shows the patient disposition. So either if the patient were dead on scene or they were transported to the hospital. And if they were transported to the hospital, what we saw the pattern is that number kept on decreasing for every month for the 2020 compared to the previous years. And so if you see this red color bar, which is 2020, it is going down compared to the previous 2 years, the number of cases transported. And obviously, if one goes down, then the number of dead cases on scene increases. That's for cardiac arrest. And then I'm going to show you opioid data. Opioid overdose, over the last 2 years we did it. We didn't include 2018 because not many agencies were on board. So 2019 and 2020, we are comparing for the opioid. And we did see slight increase in 2020, especially for some of the months like May, June, and July. But other than that, there is a slight increase. Not sure what it tells us though then. Same picture, we are seeing it in opioid rate for 100,000, that there's a slight increase in 2020, especially from May, June, and July months. And then again, it there is an increase, but not that big of a difference. What we saw over here is that the deaths were increased in 19 compared to 20, and more than 1.5% increase each of the month. Again, peak very high June and July, because we saw also during those 3 months higher opioid cases, also very high, and we saw the same thing over here. So that's about it. Yeah.
Excellent. Thank you, Vatsal. Any questions for Vatsal on the data? Now, we've definitely heard from a number of EMS agencies across the state that their cardiac arrest numbers, they kind of felt anecdotally that these had been elevated, and that was what initially started us pulling this data. So we really appreciate Vatsal and her team kind of producing this in a nice format. So thank you again.
Thanks.
All right. Next up is standing committee reports. Julie for TEPI.
Hi. Again, I apologize. I wasn't at the last meeting, which was November 19th, but a summary from what I've gathered is that the bylaws and updated roster were approved by the group with an adjustment for each region to have representation for pre-hospital EMS coordinator. So that approval resulted in roster vacancies for pre-hospital EMS coordinators representing both AIMS and NAMES. And then the group also reviewed validation scores for proposed Premier EMS Agency programs, or PEEP data. I think Ben Fisher noted that the Cactus data completeness product was unsustainable, and he proposed using data validation scores for benchmark scoring so that it could move forward. The committee made the summary to use data validation scores for PEEP status with a starting score of 90% quarterly reporting frequency, and then the amount of time to improve before losing status would be a year, with a go-live date to be determined by EMS Council. A motion was approved to present these recommendations to EMS Council. I think those were the big things, the big action items that were addressed at the last meeting.
Thank you, Julie. Next up, Josh for Education and PMD. Josh, do we have you on the line still? You are on mute.
Do you want me to fill in?
Sure, that would be great. I will message him quickly.
At the education meeting on November 19th, the members approved the minutes. They also approved their bylaws and updated roster roles. The next item, the medical decision-making capacity PowerPoint training was updated, and that has been posted for use on the education tile and at the azdhs.gov website. On a joint project with PACES, the Safe Sleep PowerPoint training and toolkit was approved, and that has also been posted. And then the last item that they discussed was looking for volunteers to review the VAD training. Update that. And that's it.
Excellent. I think Dr. Gaither has fixed his mic issues. Josh, are you there for PMD report?
Thank you, Gail. I apologize for that. Thank you for standing in for me on the education report for the PMD report. The meeting was called to order as normal by Dr. Castro-Marin. We had several agenda items that were covered that will also be covered in the meeting this morning. The first, just to mention, was to discuss, amend, and approve Table 5.1. That amendment was approved, and we will be discussing that here shortly. The second item was the bylaws and updated roster. We did discuss the current bylaws and roster. We added a toxicologist to the roster and then approved those bylaws and roster with that change. The next agenda item was adding inhaled anticholinergic agents to the EMT level. We will again discuss this further. The decision at the PMD level was to add inhaled anticholinergics to the EMT level as an optional drug. Again, that's on the agenda for later this morning. The last item that we discussed was the addition of oral over-the-counter analgesics for control of pain and fever at all levels. This was to be consistent with the national scope of practice, and that motion was passed, and we will also discuss that momentarily. That was it for PMD.
Excellent. Thank you, Josh. Next up, Julia, for PACES report.
At the PACES meeting, we approved the Safe Sleep Education PowerPoint that's now available on the ADHS website. We also have an ongoing work group for children and youth with special healthcare needs. Our next meeting will be on Monday, February 8th. Currently, we're in the midst of the EMS data collection, so the EMS survey has been distributed to stakeholders. Currently, we have around 45 responses and are continuing to collect those. The National Pediatric Readiness Assessment will start in May, so we will start promoting information about that soon. That's all.
All right, thank you very much, Julia. Next, for discussion and action items, can I get a motion to discuss, amend, and approve the MDC meeting minutes from May 21st? I'm sorry, not from May 21st, that should be from September.
This is Jason. Yeah. I move to approve.
Thank you, Jason. Can I get a second, please?
Second, Frank Walter.
Michelle Preston.
Thank you, Frank. All right, as Shelley scrolls through the meeting minutes. Are there any recommended amendments to the minutes? Hearing none, in the hopes of doing a more organized vote, I will first vote for anyone opposed to the meeting minutes. So anyone opposed to the meeting minutes as presented? Any abstentions? All those in favor of approving meeting minutes as projected, please say aye.
Aye.
Excellent. Thank you very much. Next up is a discussion of validation scores for Premier EMS Agency or PEEP program. This was just voted and approved at EMS Council. This is more just for informational purposes for any of you that were not on that meeting. We have been kind of looking at this process for I think, 8 years of trying to come up with some data standard for a PEEP status. EMS Council did approve, based on TEPI's recommendation, utilizing validation score and a validation score greater than 90 to maintain PEEP status. This will be reviewed, and the go live date will be March 1st with the first 12 months of data. At the end of the 12 months of data, that current 3-month preceding or 1 month, as long as an agency maintains above 90, will ensure that they can keep PEEP status. So I just wanted to make sure that this group was aware of that. We have been discussing some type of data standard for many, many years. So that was approved at today's EMS Council. Next, we just wanted to open briefly about any concerns or questions regarding COVID and EMS as it's been affecting our community. So wanted to just open the table for any questions or concerns in regards to that. All right, hearing none, Shelley, if you can just project the bulletin. I wanted to make sure, especially MDC, that there is an awareness that this does address some specifics, which really involves kind of medical direction as well. So this was sent out via our Gov delivery. So there was the executive order regarding Good Samaritan for healthcare workers and EMS providers acting in good faith. This was extended through March 31st. Some adjustments to rule waivers regarding CON boundaries. Most importantly, I think for the medical direction community is recognizing that there is an emergency measure which allows all levels of EMCTs to administer COVID-19 and influenza vaccines and perform diagnostic testing. However, it does require prior written approval from their administrative medical director. This emergency measure is in place for up to 18 months. And we did update some of the training guidelines for COVID-specific treatment and triage in the pre-hospital setting, and those are on our COVID website as well. So we just wanted to make sure that this group was aware of that. Any questions or comments about any of those items? All right, thank you. Next, if we can get a motion to discuss, amend, and approve PMD approved updates to Table 1, the EMCT drug box, and Shelley can present that for us to see. The proposed additions, if you can scroll, I think, to page 2, Shelley. You can see highlighted here, there was a proposal which was approved at PMD to add in ipratropium bromide to the EMT and AMT level as an optional agent. So this would allow an EMT to administer this alongside albuterol. It's listed separately on its own line just because of the fact that it is not a requirement. So it would be up to that agency's medical director. So we wanted to make sure that that was optional for those 2 levels, but it would still be the requirement for EMTI and paramedic. And then on page 3, if you can go to that, there was also a recommendation from PMD to add over-the-counter analgesics for pain or fever as an optional agent for all levels of EMCTs. Those were the 2 recommended changes. If I can get a motion to discuss, amend, and approve.
So moved, Frank Walter.
Thank you, Frank.
Seconded, Jason.
Thank you, Jason. All right, I will open it up for discussion or comments. I hear typing, but I don't hear any comments. So hearing no comments or questions, we will open it up to a vote. Again, just for ability to make sure we capture any votes against this. So anyone opposed to the 2 additional changes to the Table 1? All right, are there any abstentions? All right, hearing no abstentions or opposed, all those in favor, please say aye.
Aye.
Aye. Aye.
Aye.
All right, the motion is passed. Thank you very much. Next up, if we can get a motion to discuss amended approved, PMD approved updates to table 5.1 scope of practice. If I can get a motion, please.
This is Jason. I'll motion for that.
Thank you, Jason. And if I can get a second, please.
Foster, second.
Thank you, Kevin. All right, just to give a little bit of update on this, we had brought this to this group at the last meeting in September. EMS Council had identified some specific issues they wanted to go back to PMD for review. Shelley and myself met with Brian Smith, who had kind of reviewed with us and had kind of pointed out a couple areas that were in conflict to rule. So we worked with him to come up with some adjustments to make sure that there was no conflicts in place. This updated version was then taken to PMD and PMD approved it, and EMS Council approved it at the last meeting as well. We will go through and show the highlighted changes. If you can see here on the first page, CPAP, there was an initially a request to have this be checkmarked for EMT level. However, it was pointed out that not all EMTs in Arizona have medical direction, and the feeling was that if an EMT is using CPAP, they should have medical direction. STR captures that requirement, so that's why that was added in. End-tidal CO2 monitoring was also added back to being a STR because that's not currently in the national scope of practice at the EMT level. If we go to page 3 at the top, we try to address immunizations. Immunizations are in a few different places in our rule book. Currently, if you look at the link where you see that blue box with a syringe in it, that blue box links back to R925-505, which is part of our rule, which has specific requirements that for EMTIs and paramedics to administer immunizing agent. And so we wanted to make sure that if we listed immunizations, that it was very clear that that requirement was still in place, linking to that section in rule. The next line below that, we just combined, instead of having 2 separate intranasal lines, we moved the check mark to the EMT box. The rationale behind that was that at the EMT level, the medication that they can give intranasal is Naloxone, and we did not feel it was necessary to specifically say it had to be a pre-measured dose. As part of the executive order that was passed several years ago, there is a standing order for EMTs to be able to administer Naloxone, and they can get that in a variety of different formats. So we wanted to kind of bring that into alignment, which led to the deletion of the next line. And then at the bottom of page 4, we just moved thrombolytics to the section, and that continues to be a STR. So those were the updated recommendations that were approved by PMD and EMS Council. Are there any questions or comments about any of those? Sorry, was that a question? It's from a 989 number.
No, that is Jason.
Thank you. Any other questions or comments? And just as a reminder, if this does get approved, this would go through potentially the exempt rule writing process, which would require, before it goes live, a posting, I think with a 30-day grace period for public comment. So again, for voting purposes, I'm going to have if there's no further discussion, any opposed to the updated scope of practice changes? All right, hearing none. Any abstentions to the updated scope of practice changes? Hearing none. All those in favor of approving the table 5.1 scope of practice updates, please say aye.
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 All right, excellent. Those are approved. Thank you very much. Next up on the agenda, Dr. Spate is going to give us a brief update on the Epit TV project. We will go ahead and stop sharing our screen so that you can share yours, Dan.
Thank you, Gail, and thanks for the invitation. At EMS Council, we were not nearly as good at making it through our agenda. So I had to it was like 100 miles an hour, hair on fire. So hopefully I'll have a little more time to explain this in this one. Okay, is that, are we happy? Is that coming up?
Looks good.
Okay, so I'm sure certainly everyone on this committee knows the essence of Epic. For those who are listening in or watching new, just in brief, it was the statewide, and as you can see, truly statewide, more than 90% of all TBIs cared for by EMS and taken to trauma centers statewide ended up being cared for by more than 130 EMS agencies who were trained and certified in the Epic TBI guidelines, which are the nationally vetted guidelines. And you can see the amount of training going on was massive. We ended up with just short of 22,000 major traumatic brain injury patients over 8 years, with basically 5 years pre and 4.5 years pre, a half year of run-in on average, and 3 years of post-implementation, and almost 4,000 intubated patients. The guidelines, although extensive, 82 pages long, can be boiled down to aggressive prevention and treatment of the 3 H bombs: hypoxia, hypotension, and hyperventilation, which really is hypocapnia. As all of you are very aware, you can hyperventilate, which is too fast, or overventilate, which is too much, or both. And you can actually still have hypocapnia even if you're not going too fast if you overventilate. But O doesn't fit into the 3 H bombs, so there it is. Anyway, this was the core of, all of you I know familiar with the JAMA publication last year. This is the sweet spot group with severe TBI. So moderate is the AIS head region 1s and 2s. 3s and 4s are severe, and 5s and 6s are critical primary traumatic brain injury. As you can see, the group in the middle, which were the most likely to be impacted, we anticipated that, and this was actually part of the a priori severity-based sub-analysis plan. 3/4 of them had severe TBI anatomically. And again, this is true TBI. This is not presentation. This is not Glasgow coma scores. This is actual true anatomic diagnoses at the end of hospitalization. Amazingly enough, we had a doubling of the adjusted odds ratio for survival in the severe group after, and in the intubated severe cases, a tripling. This just came out a couple of months ago in Annals of Emergency Medicine, the pediatric group. We actually published the under age 18 in Annals as the primary, just because they made us. However, this is the less than 21, which was actually the a priori subgroup, because the NIH funded it, and that's their definition, so we used it. Anyway, bottom line, really remarkable outcome here with adjusted odds of survival of 5 after implementation in patients less than age 21. And you can see the positive pressure ventilation group. So this is bag valve mask and supraglottic airway and intubation, again in the severe, 3/4 of the cases that had severe. And amazingly enough, 7.5 adjusted odds. As Franco pointed out in the first STAB meeting this morning, this is only 15% of the total EPIC study. So we do have wide confidence intervals. But that's, as you know, that's redundant basically with pediatric studies. We actually had almost 4,000 pediatric cases. So it's still the largest EMS pediatric TBI study by far that worldwide that we're ever aware of. And interestingly enough, there was in the advanced airway and in ETI, even in the children, you can see nearly very, very close to statistically significant. But the positive pressure ventilation group had a p-value of well less than 0.01, highly significant. So really, really striking findings. It's important to point out here that when you're looking at this is the all age here, right? A tripling in intubated severe after of adjusted survival. And here in the less than age 21 and positive pressure ventilation. When you're looking at this, make sure you don't read any of this as, for instance, in the endotracheal intubation group, don't read any of this as basic versus advanced airway questions. In every one of these analyses, we took the groups before training, right, to aggressively prevent and treat the 3H bombs. And this was the entire positive pressure ventilation group before versus the entire group after implementation. Obviously, the two most pertinent there would be prevention of hypoxia and prevention of hyperventilation. We suspect the prevention of hyperventilation because of the dramatic changes we saw in decreasing hypocapnia was a big part of this. This is the effect of implementation. This is not the effect of making any, in fact, we did not tell them when to do basic or when to do advanced airways. All we did was emphasize that if basic airways fail in patients with GCS less than 9, just according to the guidelines. But we did not intervene at all on telling them which kind of airway to use. But what's striking is it doesn't matter whether you're looking at all active ventilation, ventilated patients, or here ETI plus supraglottic advanced airways, or ETI alone. What you're always seeing is dramatic differences, at least at the point estimate here, even though these are not statistically significant technically, dramatic point estimates of improvement. We didn't answer any question really about basic versus advanced. What we did answer was, whatever you do, you should really pay attention to ventilation because it's profoundly important. We kind of beat this up and went through it. So again, this is the all age where you see, in this case, all of these are highly statistically significant. You can see that the lower end of the 95% confidence intervals are way above 1 on all of these p-values being less than 0.001. And this is in all ages again. So regardless of which airway you're used, proper ventilation is impressive. This is brand new. I'm giving you a series now of these. We're all a priori questions, but they are secondary analyses, right? So these are none of these are primary hypotheses, and none of these were we designed or powered to answer the question of one versus the other. But these are funded now by a grant from the DoD, where we're unpacking 18 really consequential questions. And this is really fascinating. As most of you know, the guidelines were developed, the TBI guidelines were developed primarily based upon isolated traumatic brain injury issues. There were plenty of question marks about multi-system TBI because most of you know, if you're talking about all of you know, I'm sure, if you're talking about non-TBI patients, patients who have uncontrolled hemorrhage in trauma, the treatment of hypotension in the field has been an area of controversy for 20 or 25 years, and less controversial, almost not controversial at all, in penetrating abdominal injuries, obviously, basically keeping them alive until you get them to the operating room, and then aggressive blood products rather than giving them crystalloid, etc. But in TBI, they really clumped the guidelines, for lack of any more information, clumped the guidelines really all into one guideline and said anyone with TBI, whether they're multi-system or not, should be treated that way. And of course, permissive hypotension has not ever been part of the guidelines, but some have questioned whether it should be. So what we found was, not surprisingly, in multi-system traumatic brain injury, they were 4 times more likely to be hypotensive, and they were twice as likely to get large IV fluid boluses, defined as at least 500 cc's. And there was also great evidence of boluses being given, even in very short, where they didn't have enough time to get a lot of fluid in, but it was obvious the intent was that they were bolusing patients who were hypotensive, even if they only had a few minutes to do so before arrival. And this is really, really fascinating, right? Here's the isolated TBI. Again, as far as we know, this is the only data in the literature anywhere that tells us about implementation in these 2 subgroups. So isolated TBI, all ages, in severe, notice basically a 60% adjusted odds of survival in isolated TBI. And very interestingly, here's the multi-system TBI, and the adjusted odds there are 2.5. Again, I'll go back. We've been incredibly careful to make sure we are not comparing, because we were neither designed nor powered to compare isolated versus multi-system TBI. But what is statistically accurate to say is, in the Epic study, patients with severe TBI with multi-system trauma were at least as likely to benefit from implementation of the guidelines as those who had isolated TBI. And this is a big surprise to a lot of folks. We're writing this one up now. This is going to be fun to get out there. Probably lots of editorializing on this, and a lot of fistfights will come up. Really fun. And so you may have questions on that if we have a few minutes for questions at the end. Air and ground, and again, this is not air versus ground. We did not design nor have the power to ask the question of air versus ground. But notice, this is really striking. The ground transported patients, this is all ages with severe TBI, had you can see here, about a 3/4, 75% increased adjusted likelihood of survival. And the patients who were air transported with severe TBI, a tripling of their adjusted odds of survival. Another thing that I would caution about comparing these two, so it's striking that either ground or ground plus air was positive on its own statistically. That finding alone is a big finding of Epic. But it is interesting because one way to view air transport here is that this is essentially 2 doses of Epic, because this is comparing patients who had both ground care, ground-based EMS first response care, and then air transport, who were obviously untrained, versus both ground and air after. So one interesting thing is if there's a trend towards stronger odds of survival here, perhaps this is because you get both ground and air, which is functionally a double dose of guideline care. Really interesting. Again, we're writing that one up, and that's going to be fun. Close to the end here, so we'll have hopefully a few minutes for questions. So this is all ages in severe TBI, right? This is the main Epic finding right here of the main study across all ages. So a doubling of adjusted odds of survival, right? And so again, this is an a priori question, even though this is not this is a secondary analysis, but it still was a question we had in advance. So this line then is we removed everyone who is age 80 and greater. And notice, every time we move an age 5 from the elder group, right? So here we've removed everyone who is 65 years or older from the data set. And amazingly enough, you can see this is so rare in biology, right? To find every single one of these moves to the right. Every single one moves to the right, all the way down until pediatrics. And so this is, although this was, again, we were not powered nor designed to compare the effectiveness in, say, adults versus children. That was not, we can't say that. What is striking is this is, as I told the EMS council, if you're chronological snobbery would say, hey, I'm in my 30s, I'm still young. No, you're already elderly for TBI. Really striking that all the way down to these ages. So this is really pretty decent evidence for the plasticity of the resiliency of the pediatric brain, especially if properly treated in the early stages of care. And then finally, this is the last piece. The association between the intervention and the improved outcome was very strong for the first 18 months after initial training, but then began to fade. So if you think functionally on average, the post-intervention period was about 3 years in Epic. So our mistake was we went too long. So why did this happen? And we think it's because we had control of initial training, but we did not have. We offered and gave materials and resources for doing retraining and refreshing, but we had no control of that, and some clearly literally never did a training or refreshing. And it really points to the need for constant vigilance. And I'll just finish. This is our last data slide here. So notice there's really 2 striking findings here. One being that even after, this is the 1.5 to 3 year mark, right? And really think about how striking this is. There is still a highly significant improvement in severe head injury and in severe intubated head injury, even in the second half of the post-intervention period. So that in and itself, that resiliency is really striking. And we have ideas about why that might be, but in any case, it's very promising that even this far out, there was still a statistically significant difference. But here's what's really striking, right? Here you've got basically 2.5 for the first 18 months, goes to 1.7 for the second 18 months, and here almost 5 goes to 2.5 for the second 18 months. So one of the things that's really optimistic to me about the findings of Epic is the overall, remember the overall number here for all 3 years was 2, and the overall number here was 3 for all 3 years. This is showing that it's possible that the overall published adjusted odds were actually very conservative compared to what can happen if you really stay focused and you continue to do refresher, and if you can keep this early post-intervention changes, we may be talking about odds ratios that we've really never seen, especially in something as recalcitrant as improving TBI outcomes. And whenever we present, of course, we always have to thank the EMS agencies of Arizona and fire departments, just really an incredible partnership that we have, more than 130 of them participating in SHARE and Epic. And then, of course, the Department of Health Services, because if we were not in partnership with the DHS, we, of course, would never be able to do public health initiatives like this. So I'll stop there, and Gail, I'll turn it back to you. If there's time for questions, I'm happy to answer anything.
Excellent. Thank you very much, Dan. Are there any questions for Dr. Spate? All right, hearing no questions, any agenda items that the group would like to be considered for the next meeting? All right, call to the public. All right, summary of current events. You can scroll down just a bit, Shelley. Those are attached below. These are, of course, continue to be in virtual format. Our next meeting will be May 20th at 12 o'clock, likely to be virtual again unless something dramatic changes. Otherwise, we will continue this format. We really do appreciate everyone's flexibility with that. Hearing no further comments, can I get a motion to adjourn, please?
You're muted, Dan.
I'm back in case there are, now the last thing I ever wanted to preempt though is a motion to adjourn. But I am back. I am back. Yeah, that's a good way to lose my seat on the on the commission, right? No, if there are any questions, I'd be happy to respond.
Thanks, Dan. I don't think we had any questions that came up there.
Okay.
One
last shot though.
One other current event, and then I'll make the motion to adjourn. There is an advanced hazmat life support provider, instructor, and rad new course that'll be virtual on 17, 18, and 19 March. And anyone is welcome, and we'd love to have them.
Excellent. Thank you very much, Frank.
And I move to adjourn. Thank you.
All right. Thank you. All right. Thank you, everyone. We really appreciate your participation today. Have a good day.
Thank you, everybody.
Thank you all.